Hey, good afternoon, everyone. I think we will give folks just like another minute to sign on, but we have a fair amount of material to get through, so I want to make sure we've got time. So we'll give everyone like another minute and then go ahead and get started, okay? All right, I am back. Hi, everyone. For folks who don't know me, I'm Maura Cyphers. I am Nami, Maryland's policy and advocacy consultant. I started out as a volunteer with Nami 10 years ago, I want to say. At least I spent a little time on their board. I have worked in and around Maryland politics and policy and advocacy at the General Assembly and at the county level for 15 or so years. So I've had a long relationship with Nami, and it is just my absolute pleasure to represent you guys and work with Kate and Danielle and Mackenzie and just everyone at Nami and the board. So wanted to kick it off with a thank you. I usually do like PowerPoints or have a lot of written material, and I figured today I'd show my face at the beginning and just reset a little bit, because I think we've got some new people on the call today, which is really exciting. So if at any time you've got a question, put them in the chat. I will do my best to answer them, and if I don't have an answer for you, I will follow back up. So want to start with a quick session overview. The Maryland General Assembly session adjourned sine die last Monday at midnight. So session ended about a week ago. The dust is settling. The governor has signed a few bills, and we're kind of off to the races on all the bills we've passed and working on implementation there. But just backing it up a little bit, the end of last session was really abrupt because of the COVID outbreak. And so this session, during the interim, the presiding officers, otherwise known as the Speaker of the House, Adrian Jones, and the Senate President, Bill Ferguson, worked really hard to implement a lot of health and safety protocols and technology upgrades. So it was regular testing for members, aside from legislators, press, and a few select staff. The State House was closed to lobbyists, advocates, the general public. And so going virtual really meant that we had to figure out some different strategies to be successful and make sure that legislators had the information they needed to take the votes on our bills. And conversely, it added, I think, an element of difficulty just with meetings. Things get a little bit lost in the virtual world. So being able to gauge how important something is to some person or another group, or even just running into folks and at the last minute being able to say, hey, what do you think about this? Or what if we change that? And so I think that added really a totally, entirely new dynamic, especially for NAMI, because we work really closely with the Behavioral Health Coalition, which is run by the Mental Health Association of Maryland. And there are advocates, policy experts, other lobbyists like myself. We meet in person weekly in a normal year, and then meet by phone weekly too. So we have minimum 2 kind of internal legislative coalition meetings, and even those were a little bit harder to do convening on Zoom. So definitely I feel like this word has been grossly overused, but just totally unprecedented. And frankly, it was a little bit like business as usual. Every session we're approaching about 3,000 bills that, if they're introduced on time, get a hearing and need to be considered within the 90-day time frame. During the 90 days, we work 6 or 7 days a week because, it's such a compressed schedule. And I'd say overall, this was a good year for behavioral health policy and funding. Tragically, I think it really took the pandemic to highlight the necessity of better resourcing crisis services, pushing for telehealth accessibility, and addressing racial health disparities. Just to put this in context, a recent survey done of Marylanders, I think 40% reported having feelings of depression and anxiety directly due to their concerns about the pandemic. This session, and in relation to a bill that we were working on, we learned that crisis calls into crisis hotlines across the state increased at a staggering rate, and especially for Marylanders at risk for suicide. And I think prior to the start of the pandemic, deaths related to substance use, and I think opioids were on a slight decline, and they are up again. I think drugs and alcohol, it's more than 10% where we were last year, and opioids, it's about 15%. So substance use, mental illness, and then finally, and I'm sure folks on this call have seen it, but there was that study done last fall of almost 70 million people that showed 20% or 1 in 5 patients who contracted COVID developed a mental illness within 90 days of contracting the virus. So the mental health fallout from the pandemic is far from over. And I think, fortunately, a lot of the work that the legislature accomplished this session represents some true victories for Nami grassroots members and families, including a few bills that we have supported or worked on for many years. So I'm going to hop into bills soon. I will say we really missed having the day-to-day camaraderie of being with staff and coalition partners and legislators, but I think it was pretty inspiring to see how hard folks worked to make the virtual session work, and putting forward some pretty incredible policy proposals during this time. So, Nami Maryland has kind of 2 guiding policy documents. They are both available on the website. If I was a little more technically adept, I would try to link you to them on this, but GoToWebinar is not my usual platform. So we have the NAMI policy platform, which is the kind of guiding principles. If you think of an issue, there's a little bit of background and NAMI's position on it. And I think ours is 12-ish, maybe more now, pages long. NAMI Nationals, which I recommend you check out. And if you have questions and can't get a hold of anyone, that is a really good resource document, is like 70 pages at this point. And then we also have our policy priorities, and those are kind of larger subjects that guide my work and staff's work, not only during the General Assembly, but all year long. And so our 3 or 4 big ones are diversion, so diverting individuals with mental illness from the criminal justice setting and into a public health setting. In Maryland, I think the numbers are still, you're like 2+ more times likely to start mental health treatment in jail than you are in a healthcare setting. Addressing racial health disparities, I think, has always been something of a priority for NAMI. We have focused in the past a lot on cultural competency and reaching out to underserved communities, but the nature of the world in this year has really brought that issue to the fore, and the Legislative Black Caucus did an incredible job with a package of bills that we'll talk about that NAMI helped get passed and worked on and supported. Increasing access to care, always a perennial issue. Gotta break down barriers, and they exist everywhere. Early intervention, the sooner folks get treatment and are aware of their diagnosis, the better the outcomes. And I think as the years go on, early intervention is just going to become more and more of a priority because the, accessibility of crisis services for youth in Maryland is non-existent, and it's growing a little bit, but it's still not where it should be. And there's been a lot of talk with our huge education overhaul of making sure that we've got some school-based mental health services, and then the Biden administration is putting forward hundreds of millions of dollars to help with additional community wraparound services. And so making sure kids, we're meeting them where they are, and if they are in and out of school time program, or working with a community school, where should we be diverting those resources to reach those kids? So I think those are kind of the large subject issues under which you'll see when our final report comes out later today, kind of how we organize our thinking. But those are our big policy priority areas. So just a little bit of background about session. Doesn't look like we have any questions yet, and so I will pop into bills, and I can actually try and share my screen if folks don't want to. Let me see if I can find it. There we go. All right. So here's our end of session report. I can put it in the chat. I just need to do like probably one more copy edit. But under our first sort of policy priority area is diversion. So Nami fights for policies to get people help, non-handcuffs, includes expanding access to crisis services, promoting best practices in de-escalation and diversion of people experiencing psychiatric crises to treatment. I think you guys have heard about this bill. Thank you so much to the affiliates who helped us get out, I think, multiple advocacy alerts on this one. What this bill does, Senate Bill 286, House Bill 108, Nami was approached by Senator Malcolm Augustine and Delegate Laura Charkoudian. Delegate Charkoudian's from Montgomery County, and her district has had 2, I think, police-involved shootings of someone in crisis in the last 2 years. Senator Augustine is from Prince George's County and is, a true champion on behavioral health issues too. And so they came to Nami and said, what can we do? What are some things, we can do to get law enforcement out of the equation? And so we worked with the bill sponsors to put together this bill. It builds on an existing program that NAMI supported 3 years ago, the Behavioral Health Crisis Response Grant Program, which I think is now funded at $3 million. And so we, as introduced, the bill would have had $10 million of funding annually. Unfortunately, the House at the last minute cut it down to $5 million, but we've got a guaranteed funding stream of $5 million of crisis services for the next 3 years, which is a $15 million investment. And when you look at what the Behavioral Health Administration has already funded, they are helping stand up crisis walk-in centers across the state, focusing on youth outreach. There's a wide variety of things. 30% of this funding stream, so about $5 million a year, will just be dedicated to the establishment of mobile crisis teams. And we slightly tweaked the definition of what a mobile crisis team is. We're certifying that they're 24/7 and culturally competent. I think every jurisdiction has a mobile crisis team. I think, what is it, 14 or 19? 14, it's right here in my notes. Out of 24 counties have a mobile crisis team. Not all of them, very few are 24/7. Everyone has a 24/7 crisis hotline for the most part, but what we want to do is when someone's in crisis, they are connected to their mobile crisis unit. And ideally, there are specialists coming out who can help de-escalate, stabilize, connect someone to services. And law enforcement is not the first line, and they're not the first call. Our law enforcement officers have done a great deal of training. NAMI has spearheaded significant efforts and change on crisis intervention teams, but the bottom line is that individuals in crisis are safer when, you know, their first, I think, interaction is not with a law enforcement officer who may or may not be trained and, you know, who may or may not have the faculties and kind of resources to deal with that. So this bill is an awesome success, and we're really pleased. It's a really good bill. We had some awesome help from Bhsb, Behavioral Health System Baltimore. They are operationalizing the GBRICS, which is a regional crisis plan that I think is getting an infusion of $45 million. They're piloting a crisis hotline, and just really felt like this kind of dovetails nicely with what they're working on. The Behavioral Health Coalition voted to support it. They made it one of their priorities. The Mental Health Association, On Our Own of Maryland, MACO. I think in all, in the Senate, we had 23 written pieces of testimony submitted in support. And so it was a really good coalition victory and some serious money for crisis. And then also in diversion, this is kind of the other big one. Interesting year on the diversion front, because usually I feel like there are a lot more bills related to diversion. And this year it was a little quieter, but I think overall there were, you know, 30% fewer bills introduced. So the Maryland Behavioral Health and Public Safety Center of Excellence, this legislation stemmed out of some of the work Kate, Nami, Maryland's executive director, did directly with Senator Fry Hester, who secured a SAMHSA grant to run what we called the SIM Summit, so the Sequential Intercept Model, a summit of stakeholders over 2 days in November. And this is what came out from it. And it's sort of based on the Center of Excellence we established in one of the governor's executive offices a year or two ago. And I think there's a lot of staff and goal overlap here. And so what the sequential intercept model does is really importantly takes a look at the state and is going to say, okay, where are people with mental illness entering the criminal justice system? And then where can we stop them? And so sequential intercepts are kind of like filters. And so if you can stop them at intercept 0 or intercept 1, so that's when they're still in the community and they may not have been arrested, then you're in a better place. But there are intercepts all the way down to, you know, upon arrest and working with the judiciary, and then incarceration, release, preventing recidivism. And so it's a really cool model. And, you know, Maryland's counties have implemented varying degrees of some intercepts. And so I think this will help us better target where, you know, there are places that, you know, we can make sure that we're, you know, approaching individuals with mental illness equitably and avoiding law enforcement use when possible. Addressing racial health disparities. So like I mentioned at the top of the call, this was a big priority for the legislature this session. Maryland Speaker of the House, Delegate Adrienne Jones, she is not only the first woman speaker, she is the first Black presiding officer in Maryland's history. And she came in with a Black agenda, is what she titled it, and it was wildly successful. But there were some really strong focuses to ensure that we are addressing racial health disparities. And we know, I mean, all studies show in underserved areas of our state, people with chronic conditions like hypertension, heart disease, asthma, diabetes, and substance and mental health disorders always have worse health outcomes. And, you know, it's due in large part because they're not able to get the care and treatment they need. And, you know, again, tragically, COVID has exposed these inequities. And I think the somewhat silver lining is that forcing us to confront racial health disparities and lack of access to mental health care in general is going to mean better policy work and better investment. So on these bills, House Bill 28 and Senate Bill 5 passed. It requires health professionals to take implicit implicit bias training as a condition of being issued a new license to practice. And it also creates an additional and I think increased funding stream for our Office of Minority Health and Health Disparities. So they monitor and publish reports about how the state is doing when it comes to health disparities. And I believe this bill, if not the next one, also beefs up that reporting requirement. House Bill 78 and Senate Bill 52, sponsored also by Delegate Peña-Melnick and Senator Mary Washington, passed, and it creates the Maryland Commission on Health Equity. The goal of the commission is to address racial injustice and health disparity issues in Maryland. And then this would also establish a public health equity framework to eliminate some of that implicit bias, and then again to work on targeting communities that we have historically not provided adequate access of healthcare to. And then also really cool, developing a comprehensive health equity plan to address the social determinants of health, and setting additional goals to achieve health equity. So these are some major victories. House Bill 463 and Senate Bill 172. I think this one probably got the most press, the Maryland Health Equity Resource Act. It passed. It's going to be a huge infusion of almost $60 million into designated health equity resource communities. I think health equity resource communities were piloted starting in 2011 to identify gaps in accessible healthcare. And this bill, I mean, the primary focus is somatic care, but we know when there's a comprehensive approach to care that includes mental health, that outcomes are better overall. And so that was sort of Nami's position, is making sure that every step of the way there's access and availability of mental health services too in these health equity resource communities. But targeted health outcomes, and I think the advocates really feel like this will help start moving the ball on reducing racial health disparities. So I'm going to stop there really quick, see if there are questions. We've got one. How long is the implicit bias training? That's very specific. I don't know. The requirement would be, I think there's some regulation and rulemaking that has to happen on the implicit bias training, and then what the health occupations boards have to require, because some licensure updates are yearly, some are biannually. So I think there's a little bit more work to be done on, for specific health providers, what the training modules look like, how often they have to be completed, and all of that. TBD, but I'm happy to find out and keep you in the loop, Lori. All right. Oh yeah, and then House Bill 309. So this bill is just an additional reporting bill, but it also, I think, would require each health occupations board to get interesting numbers and information on the demographics of the providers that they're licensing, so we can better get a sense of who are the providers, who are they serving, and what do we need to do to be incentivizing or encouraging people of color to enter the healthcare field, or even the playing field in that regard. We have one more question on this. Who will staff the mobile crisis units? What training is needed to work on mobile crisis units? I am not a clinical expert, so I can't say what sorts of training. There is a peer element in, so a clinician comes out, but then there's a required in the bill, like a warm handoff to a peer support specialist. And so going forward, the bill would require that the state award grants with a preference of mobile crisis units who are culturally competent, who work with communities groups like Nami within the community, so county Nami affiliates, on creating and designing the mobile crisis unit. And then once someone is stabilized, then we're using peers to help connect them to housing, to additional providers, to saying, your medication's ready at the pharmacy. So I think there's a wide variety of staffing levels and training involved. So I can't speak directly to to that, but I'm happy to help connect you to, I think, folks with more of a clinical background who could tell you kind of what degree you need or level of experience and training. So another policy priority for Nami is increasing access to care. I think if you have spent any time on these calls, you're well aware that this is just an ongoing priority for Nami because there are barriers to mental health care and they exist everywhere. And if you're on this call, I'm sure you have faced them. And so in the past, we've talked about things like parity and, you know, preventing insurers from sticking the bill with consumers. And this year, the major work was done in the telehealth space, which is super exciting. So near the end of last session, Nami worked with Delegate Shetty to pass a bill that would require Medicaid to cover telehealth services for behavioral health. And the governor signed the bill into law, and then all hell broke loose with the pandemic. And the federal government and the state started kind of expanding access to telehealth and who could use it and what it's covered. And so there were, I meant to get the count before the call, I think 12 or 14 bills introduced around telehealth. And we have heard it kind of self-reporting and talking to people, and Nami's done a handful of surveys throughout the pandemic about, you know, what do people need? What can we be providing in terms of education and training and support? And telehealth has been a lifeline for seniors, families, children, those with disabilities, or in rural or underserved communities. We, I think, successfully defended all of the expansions we wanted to see. And that will really, going forward, ensure strong standards for mental health and substance use disorder services over telehealth. So we advocated for audio-only telehealth where appropriate. 500,000 Marylanders lack access to high-speed internet. As an aside, there was a big digital equity bill this year, and if you happen to live in one of those areas or have family who does, help is coming. The state has invested $300 million to go that last mile and make sure everyone has access to broadband. So remove originating and distance site restrictions. This is just some insurers can say, okay, well, you have to go to a healthcare facility to do this telehealth visit. And so this says you can do it at home. Parity, preventing health insurance carriers from restricting access to telehealth services for mental health or substance use issues. We're also requiring the Department of Health to revise their telehealth regulations to comply with the Mental Health Parity and Addiction Equity Act, and specifically to get rid of the prior authorization requirement for mental health telehealth services. And then another really important provision is the protection for consumer choice. And so making sure that consumers aren't dinged, or, you know, if they say, I don't want to go to an office, I just want to do this telehealth call from my home, that's covered and the provider is paid at the same rate, whether or not they're providing the service in their office or via telehealth. And so I think the state is going to do a study on this because I think they're worried about the long-term costs. But when you think about folks with mobility issues or, you know, even access to transit or transportation, or having to take half a day off to go drive to your provider and do your appointment and then come out home, rather than, you know, maybe being able to sneak off and do a half-hour call in your car on a lunch break. I mean, this is just really, really an important provision for consumers, because it's going to make sure that folks can stick with their providers and, you know, continuing to get help and remain in treatment. Will you get a certificate for attending today? I don't think that this is a continuing ed thing, so I will provide this end of session report though. House Bill 135, Senate Bill 84, Delegate Karen Young and Senator Ron Young. This bill permits pharmacists to administer long-acting injectables. Sure, you guys have heard me talk about this one because we like it. There are some really good long-acting injectables that help treat severe mental illness in particular. And what this bill does is say after you get your initial dose from your provider, you can just go to the pharmacy and then your pharmacist can administer that. And for patients without a PCP, or if they live in a medically underserved area, or work full time, pharmacies have better hours and they're more accessible, and anything again to make sure folks have ease of access and affordability to the medications they need to stay well. Let's see. House Bill 970. I don't know if Bill Fluke is on here. I think he sent this one to us. This is the, I believe they were calling it SIPAC for short. Maryland can enter into the Psychology Interjurisdictional Compact for psychologists. There were a couple of other provider compacts. I think they all passed, but it just is some reciprocity, especially makes sense in a place like Maryland, where depending on where you live, treatment in Pennsylvania or West Virginia or Delaware may be closer, or vice versa. If you're a provider up near Delaware, you should be able to accept patients from there too. So just cool kind of collaboration. Senate Bill 550, House Bill 872. Nami has worked with the Easter Seals on this matching grant program for a number of years. I gotta double check my number, but I think there are 400,000 veterans who live in Maryland, and they need access to mental health care and adequate funding for those services, just like anybody else. And I know prior to the pandemic, Nami was running a lot of programs at the Perry Point VA and VAs across the state. And so the bill, unfortunately, the funding got cut from $5 million to $2.5 million, but I think, like anything, it's better to get something in place and then we can grow that program versus trying to come back. And then let's see, House Bill 1344, Senate Bill 928, Delegate Kipke and Senator Reedy. This bill would have changed the danger standard for involuntary commitment. We, I think, supported the bill and the language of the bill. Unfortunately, it was late introduction, so we weren't permitted to testify in HGO. We could only submit written testimony, and then I think the bill was withdrawn in the Senate before it even got a hearing. So if the bill gets introduced late, there are all these additional procedural hurdles. It's worth noting that I think, so Delegate Kipke, he's up until yesterday was the Republican minority leader in the House, and really well respected, and serves on the Health and Government Operations Committee. And the Lieutenant Governor has really been trying to raise the issue of assisted outpatient treatment and potentially changing the danger standard. He included some recommendations about it in his Commission on Mental Health's most recent report. And I think from a Nami perspective at this point, what we'd like to see and what we're hoping for is just a little bit more leadership from either his office or BHA. And BHA, the Behavioral Health Administration, has convened a work group looking at changes to the proposed danger standard. And by and large, we support what they're doing and are trying to support that effort overall. And so for those who aren't aware, because this is a kind of arcane issue, changing the danger standard would bring a little bit more flexibility to ensuring folks with severe mental illness can be involuntarily committed, or if they choose to be committed, go voluntarily. The problem with Maryland's danger standard is how narrowly it's interpreted, right? Because basically this, the harm standard, physical harm to self or others, is truly an obstacle to treatment, because that's saying we're going to wait for someone to get so sick that they hurt themselves or they hurt someone else, and then I mean, the amount of trauma that creates for the individual, for their family, those are dangerous and volatile situations. And I think the state has a duty to care and a vested interest to adopt some broader criteria for involuntary commitment. 45 states have, I think, a stronger standard. There's also, I think, some recommendations around what is shorthand known, but I think conventionally have gotten away from also adopting the gravely disabled standard. And so that's a standard where, the harm to self can be interpreted as losing housing or, not taking your medicine and decompensating or deteriorating to the point where you're very, very ill. And then, are harm to yourself because you're forgetting to take your insulin when you have diabetes or that kind of thing. And so, that's something we're advocating for at the agency level and something we support. And I think it was a good effort of the sponsors to put in a bill to try and start having that conversation. But unfortunately, the late filed procedural hurdles really didn't set them up for success. And then want to talk a little bit about Optum, and I think we're kind of nearing the end of this too, so we'll have a good amount of time for Q&A because I think we've got a few more questions. So Optum, if you're familiar, if there are providers on the call, I'm sorry, Optum runs the state's behavioral health administrative service organization, or ASO. And so our public behavioral health system, I think we're now approaching maybe close to 300,000 Marylanders, and that's adults and children who are part of our public behavioral health system. So they're on Medicaid, and Optum runs the billing and payment system. That's what the ASO does. I think they took over last year, the year before, and their failure to create a functioning payments system meant that the Department of Health was providing estimated payments to providers for much of the past year. In addition, Optum has just profligate and capricious service denials because there's not a signature in the right place, or the new form wasn't totally up to snuff, and so it wasn't even for clinical reasons that they're denying services. It's silly administrative things that should have been easy to fix and overcome, but they have created and introduced chaos into the system. And now there are allegations of overpayments, and providers are rightfully fearful that they could be on the hook for hundreds of millions of dollars that the state may try to recoup. It's definitely a tenuous situation, and Optum has yet to provide an accounting of that would verify whether or not the state has overpaid for behavioral health services. And one wonders if they have the internal capability to even make that full accounting. And this is really me editorializing, but the stats I started with at the top of the call, I mean, the pandemic has, I think, just contributed to so many mental health issues and the deterioration of, folks who were living well and needed to go back on meds or needed to find some treatment options. And so for this population to be at risk and for providers to be at risk and fearful is just, I don't know, it's the height of irresponsibility, and it's been a really disappointing time, I think, for the Behavioral Health Coalition trying to work with Optum. And there is a bill here, sorry. So Senate Bill 638 and House Bill 919, it helps the Maryland Insurance Administration hold Optum a little bit more accountable and assess some fines. MIA has committed to doing everything they can to help keep Optum accountable, because they're responsible for managing care and paying claims in our public behavioral health system, and people need help. Early intervention. So again, I touched on this at the top of the call, but early intervention is so important, and I think will just continue to become more and more important. But one bill that I think we are all particularly proud to work on this year, the sponsors came to us right before session with an idea that actually is based on a senior elder outreach program that Maryland implemented a few years ago through 211. And so right now, 211 is sort of the general services line that can help connect Marylanders to a wide variety of services. And 211 plus one is what you press for mental health. And so this bill will create an opt-in program to help provide support and connection using 211. Nationwide, the increased mental health call and text centers offer an early picture of how Americans are coping with the coronavirus pandemic. And so basically how this works is 211 is in the process of staffing up with some trained peer specialists, and I believe potentially a counselor or clinician. And so you can call 211, press 1. You'll get connected, hopefully, to someone in your greater community. So there are some strategically placed call centers across the state. And the peer specialist or provider, they'll listen to your story. And they'll provide some validation, which I think is really important. They'll set up a schedule for check-ins. And so you can say, I want someone to call me once a week to just check in and say, hey, Maura, have you called that therapist I've sent you? Or like, how's your new med going? And so they'll be able to recommend resources to help folks manage their symptoms and hopefully connect them to services. And the bill was near the end of session renamed for Tommy Bloom Raskin, Congressman Raskin's son, who tragically I died by suicide prior to the holidays. And so I think folks in Maryland have still been reeling from his death. And I think that was a really nice way to honor him. And hopefully, in this period of social isolation, that this is a small step in ensuring that people don't have to feel so alone, and will know that, there's someone on the other end of the line looking out for them. A couple of other bills, task force to study access to mental health care and education. We supported this bill, and I think the conversation is important, but there are so many steps that higher ed can take to providing better access. The averages at larger universities, it's like one provider per 2,000 or 2,500 students, and at smallers, it's like 1 to 500 or 1 to 1,000. If you've ever been in college and tried to access mental health treatment through your school, you were likely put on a 6 or 8 or 10-week waiting list, and really had a hard time with access. So, I think the task force is a good start, but also I'm for kind of taking action, and there are so many actionable things colleges and community colleges can do. House Bill 466, Senate Bill 405. This bill passed. Nami supported it. We've been talking to Delegate Polakovich-Carr and Senator Augustine about the bill since last summer. Pretty simple bill, but I mean, just kind of great in terms of public awareness, and it just would require higher ed, so community colleges and four-year universities, to put the telephone number for Maryland's helpline, an on-campus crisis center that operates 24 hours a day, on student ID cards. And then the bill says, you can add the National Suicide Prevention Hotline, crisis text line, domestic violence hotline, or additional on-campus crisis information. Senator Eckert and Delegate Belcastro's Maryland Suicide Fatality Review Committee failed to pass. Again, it was introduced last year. Concerning, I mean, we need more localized data to better target prevention and outreach on suicide. I think the most recent numbers show suicides decreasing for white Marylanders, but for Black residents, suicide is on the rise. And so I think, again, just going back to prioritizing racial health disparities and making sure that there's investment and support and adequate access to providers is critical. But suicide prevention needs to be right up there with it. So we'll keep working with the sponsors and the governor's office to prevent suicide. And then the budget was great this year. In 2017, we worked with the Behavioral Health Coalition to pass the Keep the Door Open Act, which created a series of step-ups for provider rate increases in our budget after I don't know how many years of them always being marginalized and having a big zero next to their budget line every year. And so prior to session, the governor said, hey, I'm doing the 3.5% rate increase that's legislatively mandated, and I'm also going to start it in January, which is 6 months early. And so that was awesome. There's additional crisis grants coming down. BHA is going to administer about $15 million. So this is in addition to the bill that we passed this year. And then we need to kind of cull through some of the federal dollars coming down, but I believe there's additional dollars from the feds on mental health too. So all in all, a really busy session for having, worked virtually, but I think we were able to make progress on a number of important issues, and I'm, proud to be a part of it. And I think we get to questions here. Yeah, Robin, are we going to be able to have access to the final legislative report? Yes, Nami sends it out. So this is just a phone briefing to discuss and talk about session. And then Don Reed, oh, this is actually a great question, Don. What should local affiliate advocates be doing to follow up on the NAMI agenda outside the legislative session? Do we thank our delegates and senators? Do we ask, for example, why they failed to provide full funding for Senate Bill 286 or register our disapproval? Do we restate our interest in any bills or issues that we supported and failed to pass? Yeah, Don, I love that idea. I think that would be really helpful and have a great impact. And I'm happy to talk with you about some strategies and even say, okay, well, here's who you should talk to because they do a lot on behavioral health or they serve on the right committee. So that's one of the roles I play. And in fact, I think I'm scheduled to talk to the Howard County Policy and Advocacy Committee on May 6th. But if there are affiliate leaders on here, or if you're interested in your affiliate having some more direct conversations with NAMI's staff and advocacy team about follow-ups, about local advocacy work that you're doing and need some help or advice, we're here for that and we're happy to help. And yeah, thank yous are a great idea, and we can help customize that and provide lots of information and background. Let's see. All right, peeps. I mean, we can go off mute, or if folks have questions, you want to raise your hand. That's, I think, kind of my sine die wrap up this year. I think NAMI tracks about 100 bills, and we submitted testimony on probably 40 individual bills, and that's not counting the time we've spent in subcommittee and meetings to hammer out compromises. The last thing I wanted to make sure I mentioned too is Advocacy Day. So if you attended Advocacy Day, thank you so much. We had a lot of helpful feedback about the virtual aspect of it. Advocacy days are always a little bit disjointed and seem kind of like a schedule that keeps moving and you can never quite keep control of, but that's a little bit out of our hands because the legislature schedule is always in flux. And I think that made kind of a big splash because we heard back from a number of legislators who really enjoyed it. And, the ones who sent staff, we also followed up with to just give them a little bit of a nudge to say, hey, the Senate president made it a priority. And he spent 15 or 20 minutes talking to Nami Metro Baltimore about his own experience with, the emergency petition process and someone close to him. And I think we were able to really forge some connections and have conversations that did advance, the chances of success on some of our bills. But it's also great, kind of coming back around full circle to Don's question. It's a great way, especially if it's in person, to just build some lasting relationships of your own from your affiliate to your local elected officials, because they can be a good advocate, but you can also help them out. I mean, I think it was someone in Carroll or Harford County we met with who, for the first time, was learning about some of NAMI's support groups and, education and programs they do. And they were like, we want to add a brochure or something to our constituent services, and how can you help us, put us in touch and connect folks to you. So if you didn't attend Advocacy Day, please do it. It's awesome. And it makes a difference. Let's see, what else do we have?
Laura, we did go ahead and mute everyone, so they do have a chance to chime in if they like.
Oh, I see one more typed question. Shannon, thanks for sharing your story. Let's talk about advocacy. And then a question from Lynn: do mobile crisis units still include police? Yes. So the bill and our preference is that funding goes to mobile crisis units who remove law enforcement. There are crisis response teams in counties where there's a partnership between like a local provider and law enforcement. And so I think we don't want to disincentivize counties and municipalities from establishing mobile crisis units, but we kind of have a carrot of incentivizing and providing additional funding for those which don't. So we're not banning police or law enforcement from mobile crisis units, but we're trying to work to get local governments to acknowledge that they can be separate and successful still. All right, well, if there are no other questions, take a look for the final session report heading to your inboxes in the next day or so. And I really appreciate everyone who was able to hop on and join and talk about session. It was a long, kind of hard one, but it was, really, really different to have NAMI grassroots, doing action alerts and doing our virtual advocacy day and just helping us and being committed to, the mission and the cause, even when, we're all kind of sidelined at home. So thank you very much, and we'll talk soon.